Okay, medical brain, wake up. Here's a classic trap. A patient with SLE suddenly has vision loss, then comes back with a long spinal cord lesion. If you automatically say lupus flare, you might miss the real villain. Today's mission: spotting NMOSD, neuromyelitis optica spectrum disorder, also called devices disease. Here's the case. A 32-year-old woman with SLE, 1 year ago, right eye blindness that responded to high-dose steroids. Now, her second episode of transverse myelitis, with profound leg weakness, hyperreflexia, and bladder dysfunction. MRI shows an enhancing spinal cord lesion extending from C4 to T1. That length is the clue that changes everything. NMOSD has a signature combo. Number 1, optic neuritis, painful vision loss. Number 2, transverse myelitis, often severe and relapsing. And number 3, the mega clue, LETM, which means longitudinally extensive transverse myelitis, a spinal cord lesion that spans 3 or more vertebral segments. C4 to T1 is a long stretch, so LETM is screaming at you. The test most associated with this pattern is AQP4 IgG, also called anti-aquaporin 4 antibodies. Aquaporin 4 is a water channel highly expressed on astrocytes. In NMOSD, antibodies target this system, triggering intense immune injury, especially in the optic nerves and spinal cord. Translation: optic neuritis plus long myelitis. Check AQP4 IgG. Now here's the subtle extra clue. This patient is positive for anti-SSA, also called anti-Rho. NMOSD can be idiopathic, but it's also seen with other autoimmune diseases, including SLE and Sjogren, and anti-SSA may show up. So the presence of SLE doesn't protect you from NMOSD. Sometimes it actually points toward it. Let's do the quick "don't mess this up" comparison. In MS, multiple sclerosis, spinal lesions are often shorter, and brain MRI patterns are classic. In NMOSD, you often get long spinal cord lesions, and CSF oligoclonal bands are frequently negative. So if your MRI shows a long cord lesion and the story includes optic neuritis, NMOSD rises to the top. Here's the key lesson. Neurologic symptoms in SLE are not always lupus activity. If you treat everything like a flare, you can delay the correct diagnosis. The pattern matters. Optic neuritis plus LETM equals NMOSD until proven otherwise. Final memory weapon: NMO, chakra nerve plus marrow overload, nerve, optic neuritis, marrow spinal cord, overload, long lesion. So in an SLE patient with vision loss and a long spinal cord lesion, the test most linked to the presentation is AQP4 IgG, anti-neuromyelitis optica antibodies. If you want, I can turn this into a rapid quiz so you memorize it forever.